Hi, welcome to our Take Action webinar series. We are so excited to have all of you here and joining us. We have a great session prepared for you today. We are going to be talking about psychiatric disorder. And certainly that is a topic that has lots of interesting comments that might come along with it. And so we want to talk about what that means and how we think about it. We really want to dig deep into the basics, but also help us to understand what that means in the context of autism. Certainly whenever we start talking about the words disorders and, problems and conditions and things like that, it can bring up a lot of thoughts for people. And so we want to think about that together, and we'll be having a chance to answer some questions and really dig deep into that topic. So we'll also be having a chance to learn about effective treatments for psychiatric disorders in people on the spectrum, but we'll certainly be open and hopefully have a chance to share with you how we as clinicians and parents, as well as many of us, think about caring for people and guiding people, as well as walking alongside people who have been provided a diagnosis like this, so that we can really work as a team. So I hope today will be very helpful to many who are listening. And I am delighted to have a phenomenal team here today with us. And so let me introduce them. We have Dr. Rachel Brown. She is a physician, board certified in psychiatry and child and adolescent psychiatry. She specializes in the evaluation and treatment of patients of all ages with autism and co-occurring psychiatric disorders, including those with challenging behaviors. She has worked in this field for more than 30 years. Brenna Maddox is an assistant professor at the University of North Carolina, Chapel Hill in the Department of Psychiatry. As the implementation scientist for the Teach Autism program, her work focuses on improving community services for people on the autism spectrum and across the lifespan. She is particularly interested in training and supporting community mental health clinicians, modifying cognitive behavioral therapy for people on the autism spectrum with anxiety or depression, and preventing suicide in this population. Dr. Maddox is also a clinical psychologist with expertise in the assessment and treatment of co-occurring psychiatric conditions in autism. Melinda Odom is a licensed clinical social worker with a background in counseling and developmental disability case management. She's also the training manager for the ECHO Autism program. Ellie Madigan is the mother of a young boy on the spectrum, and she's been advocating for many years in search of resources to help her son and other individuals with autism. She's also a registered nurse. I'm Dr. Kristen Soul, and I'm the founder and executive director of ECHO Autism. And one of the most important missions that we have as part of our community is to continue learning together. We want to imagine communities where all abilities are able to live their best lives, no matter where you live, no matter where you are. We want to be able to have opportunities where people are able to access best practices, whether that be best practice mental health care, best practice early intervention, best practice medical diagnosis, advanced diagnosis. One of the things that we know is that inequity or challenges with disparities meet us where many of us are. Even in urban academic centers, there can be disparities right there. But we certainly know that in rural and underserved communities, that's where they live most. And so our mission here at ECHO Autism Communities is to really say, how do we imagine communities in a different way? How do we bring expertise and partner and grow together? And so that's part of the effort that we're doing today. And I am very excited to be part of this team and really working to do just that. So we're going to go ahead and share our content with you, and then we'll have time to discuss it after. So I'll turn it over to Dr. Maddox and Dr. Brown.
Thank you so much for that wonderful introduction. We will be spending some time today talking about co-occurring psychiatric disorders in autism, and we'll really be focused on two main areas: the recognition piece, the assessment piece, and then the treatment piece. So I'll be leading us off, and then I will be handing it over to Dr. Brown in a little bit. The main objectives we're hoping to get to today, the first here is defining a psychiatric disorder. We won't spend very long on this, but just to make sure we're all on the same page about what a psychiatric disorder even is. Then we'll be focused on what are the common psychiatric disorders in autism and how they present across the lifespan. And then ending today with some focus on what are effective treatments for psychiatric disorders in people on the spectrum. So again, just to make sure that we are all on the same page, we are referring to the DSM-5 shown here and that definition of a psychiatric disorder. So this is a behavioral or psychological syndrome or pattern that occurs in an individual that reflects an underlying psychobiological dysfunction. And I think the third point here is really important to keep in mind as we are talking today, because all of us experience, some of these symptoms or characteristics at times. If you think about anxiety, for example, we all feel anxious at times, and sometimes that anxiety is really adaptive, and sometimes it's brief and fleeting. And to rise to that level of a psychiatric disorder, to a diagnosis, which we'll be talking about today, the consequences of those symptoms have to be clinically distressing or lead to some type of significant disability or impairment in one or more areas of functioning. So just keep that in mind, please, as we're talking about these different conditions today. The last couple points about a psychiatric disorder, we don't want to include these expected responses to common stressors and losses. So, for example, feeling sad immediately after losing a loved one, that does not rise to the level of a major depressive episode right after losing a loved one. We also don't want to include culturally sanctioned responses to a particular event in this type of clinical framework. And then lastly, it must not be primarily a result of social deviance or conflicts with society. So that gets into a whole other presentation that we could do. So let's really focus today on these co-occurring psychiatric disorders in autism. And what I find really interesting is that this topic has actually received relatively little attention in autism research historically. So we just showed a picture of the DSM-5, the 5th edition. In previous editions of the DSM, certain psychiatric diagnoses were specifically precluded from people on the spectrum. So the instructions were you could not diagnose something like ADHD or separation anxiety disorder in someone with an autism diagnosis. And this was really driven by a belief that these symptoms were so frequent in individuals on the spectrum that they were just part of the autism and they shouldn't be a distinct diagnosis. Now we are learning more and more about how impairing some of these co-occurring psychiatric conditions can be in people on the spectrum. And so fortunately, we are seeing more attention to this in the research, which is opening up more doors for assessment and treatment. Still, we all have to be aware of something called diagnostic overshadowing, which is basically just a fancy way of saying that sometimes we see someone on the spectrum who has these symptoms of something like anxiety or depression, and we may just attribute all of that to the diagnosis of autism and not recognize that there is this distinct psychiatric disorder that is co-occurring with the autism. So that salience of the autism really overshadows the recognition of a true psychiatric co-occurring condition. And of course, it's very important to actually identify these symptoms accurately so that we can choose the most effective treatment option. So we do not have time today to go over all of the possible co-occurring psychiatric disorders. So we decided to really focus in on the most common, what people are often seeing in people on the spectrum. So that would be anxiety disorders, obsessive compulsive disorder, depression, and ADHD. And there's solid evidence of increased risk for these conditions in people on the spectrum compared to people not on the spectrum. So we're going to begin by sharing some general challenges and recommendations around assessment of co-occurring psychiatric disorders and autism, and then we'll spend the remaining time on these specific conditions. So in the context of autism, we know that psychiatric disorders present with many of those prototypical symptoms. So for example, people with autism can experience some or all of the traditional features of depression, like increased sadness, tearfulness, changes in appetite or sleeping patterns, feelings of guilt or worthlessness, all of those things. And to really get a thorough idea of what's going on, a multimodal, multi-method assessment is strongly recommended with this focus on observable changes from the individual's established baseline. In other words, really looking to see, what were the typical behaviors or thoughts or feelings before these concerns first arose? How have things changed? And again, does that rise to the level of being clinically significant or impairing? So in addition to these prototypical features, there are also some potential autism-specific signs of psychiatric conditions, and I've listed a few of those here. For example, changes in those focused interests. Let's say that someone is really, really interested in dinosaurs. They like to spend a lot of time researching dinosaurs and learning about them and watching YouTube videos. And then you see this change where they're not as interested anymore. They don't seem like they're getting as much pleasure out of it. Or maybe the content of that focused interest has changed to something with a darker content. Now they're looking up the deaths of famous people or methods of dying, that more morbid content. We also can see an increased frequency or intensity of repetitive behaviors when people are entering a kind of new onset of a psychiatric disorder. Increased insistence on sameness or some of that rigidity. And then we can also see regressive behavior or decline in self-care. So anxiety specific, this can look a lot of different ways in people on the spectrum. We've listed some of the main things up here, different signs that you may see behaviorally of increasing anxiety. So I won't go through all of these. I do want to highlight a few. The unusual phobias, there is research to suggest that people with autism have a specific phobia around something that is potentially an unusual content or topic. So a phobia about the color yellow, or a phobia about men with beards, things like that. So sometimes you may see these more unusual fears, and they are really getting in the way and impairing that individual's functioning. We see verbal perseveration when individuals on the spectrum are feeling anxious. They might be stuck on kind of the same topic, asking for a lot of reassurance, asking a lot of what if questions, well, what if this happens? What's going to happen if you can't come get me from school tomorrow? Things like that. And then we do want to keep an eye on increases in self-injury or a new onset of self-injury, and make sure that we're asking some follow-up questions to understand what's going on there. All right, Rachel, I think I'm going to turn this part over to you about OCD.
Yeah, glad to. Thank you, Brenna. And Brenna's going to be running the slides for both of us. So you'll hear me talk a little bit about, you'll hear me say every so often, next slide, please, because she's helping me out with this. So yeah, obsessive compulsive disorder it has historically been thought of as a form of an anxiety disorder. And so it's sometimes quite difficult to actually pick apart whether you're looking at somebody whose repetitive restricted behaviors and the focused interests are part of their autism spectrum disorder, or whether actually what you're looking at is actually an obsessive compulsive disorder. And sometimes the autism-related restricted interests are actually described colloquially as that particular individual's obsessions or obsessional behaviors. So, and there's a difference between what in general communication we talk about as obsessions and what we in clinical environments think of as obsessive behaviors that are related to obsessive compulsive disorder. So this is one of those conditions where what you need to be doing is doing a really careful assessment. And the important piece of this is that if what you're seeing in terms of obsessions is part of the autism, then actually anxiety typically will go down when that person is engaging in whatever behaviors or interests or ideas or thoughts are part of the restricted repetitive behaviors. Whereas if it's an OCD related problem, then the obsessions are often accompanied by actually an increase in anxiety, and then compulsive behaviors that are directed at relieving the anxiety that's part of OCD. Next slide. So and when you move from the thoughts, which are the obsessions, to the behaviors, then the compulsive behaviors in OCD are there to actually neutralize or alleviate the obsessive thoughts and the accompanying anxiety and negative affect. So when you're looking at OCD, it's important to actually identify what happens before you're getting into the compulsive behaviors, what the exact behaviors are, and and then what are the consequences of the compulsive behaviors, whatever the behaviors are. And what you're looking for here is the functional link between obsessions and compulsions. With the ASD, the autism-related repetitive behaviors serving a variety of different functions, including self-stimulation and anxiety reduction. And I think this is back to you, Brenna, for the next few slides, talking about depression.
That is correct. Great. Thank you so much. So again, kind of a common theme here is this potential difficulty with disentangling the symptoms of the psychiatric disorder from the characteristics of autism. So now we're thinking about depression. And we know that individuals with autism do experience depression at high rates. Recent research suggests that it's approximately 4 times greater rates in people on the spectrum compared to the general population. But again, it can be really hard to detect this when there is such significant symptom overlap at times. Things like social withdrawal, irregular sleep patterns, flat affect, diminished eye contact. These can all just be seen in autism. So we really need to spend some time asking a lot of good, thorough questions to figure out if there's also co-occurring depression. Unfortunately, there are not many assessment tools that have been designed or validated to assess depressed mood in people on the spectrum. So we know that it can be extra difficult, particularly when people have social communication difficulties and may have a hard time describing some of their internal experiences with emotions. So I think as a clinician, what I really try to do is look for those observable changes in behavior. Of course, ask those questions about the internal thoughts and feelings as well, but asking family members if that is appropriate and looking myself at those observable changes in behavior. So we've talked about a couple of these already, that loss of pleasure, refusal to engage in previously motivating activities. One thing I've seen a lot in my own clinical practice is this increased focus on negative topics that you didn't see as much before in your interactions with this individual. A decline in self-care, some of that regressive behavior, so maybe not. This can go hand in hand with the decline in self-care, not taking showers as frequently, not combing or brushing one's hair. We see exacerbated problems with eating, sleep, or concentration, and then weight changes, which would go hand in hand with that. All right, and I'll turn it back over to Rachel to talk about ADHD.
This is one of those issues where that distinction between somebody with autism, where the hyperactivity, impulsivity, inattention is part of the autism spectrum disorder, or whether it's part of the ADHD, can be really quite difficult, and that's for a number of different reasons. Of course, there are lots of motor symptoms often in both conditions. So ADHD is characterized by hyperactivity and restlessness, and you often will see that in people with autism spectrum disorders. And you also see, of course, those motor stereotypies and repetitive behaviors that are very typical of autism spectrum disorder. You can also see, and then the other thing that complicates both diagnoses, of course, is as well that both of them can be accompanied by generalized developmental delay, and of course autism spectrum disorder also often by communication difficulties. So when you're thinking about the level of activity and the length of concentration and an ability to attend in a particular child, you've got to take into account the overall developmental level of that child. So of course, younger children have more, the attention span is shorter. Preschool children are often very active, sometimes quite impulsive. So you need to look at what is the generalized development, the general developmental level of that child, assessed both by developmental level and by chronological level. And in kiddos who do have some developmental challenges, assessing by chronological age may lead you to an overestimate of the child, of what a child should be able to do in terms of sitting still and concentrating. And so you may actually make a diagnosis of ADHD in that particular child, when actually what you're seeing is behaviors that are developmentally appropriate, even if they are not typical of the child at that actual chronological age. Next slide. The other thing that makes it difficult is that both of these conditions, autism spectrum and attention deficit, are actually developmental conditions. So the change that from baseline that Gwenna talked about a little bit, that's so helpful in diagnosing anxiety and depression in somebody with autism spectrum disorder and indeed somebody without, is not nearly as helpful in trying to pick apart whether you're looking at somebody whose behaviors are part of their autism or whether they merit an additional diagnosis and treatment for ADHD. These are both really common conditions. The population prevalence of ADHD is around 5 to 8%. And they're also conditions where symptoms, the difficulties arising from those symptoms are typically present across settings, and over time, they shift somewhat with development. But in mood and anxiety disorders, you see episodic changes, things get better, things get worse, and there's actually a baseline there where the diagnosis is not appropriately, the symptoms are not present. And in kiddos who have autism and ADHD, or indeed adults who have both conditions, the symptoms are there really pervasively and persistently across time. Next slide. So there are a couple of things that I think are sometimes important that I like to think about. One of them is about this whole business of inattention, which is characteristic of ADHD. And the thing that you see with ADHD as opposed to autism is that kiddos who have the ADHD diagnosis can't initiate and maintain attention, especially if it's routine tasks. They tend to be more novelty seeking, so they like different things, and quite often you'll see attention shifting in somebody with ADHD between topic and topic, and they have real difficulty staying on task. Whereas in autism spectrum disorder, the inattention tends to be, the inattentive symptoms tend to be characteristically different in that somebody who has autism spectrum disorders only and doesn't have the ADHD as an additional diagnosis, their attention will focus on their preferred task, which is often part of the repetitive restricted behaviors and that limited interest that's part of the autism spectrum, and that shifting attention away from that preferred task may be where the difficulty lies. The other thing is that the repetitive behaviors in ADHD tend to be very variable. The behavioral hyperactivity and impulsivity, part of what you see characteristically is lots of hyperactivity in different directions, focused on different activities. And in autism spectrum disorder alone, you see the increased behavioral activity, but it's often repetitive, sometimes stereotyped behaviors. So that helps me a little bit in trying to pick two of them apart. But, and here's where the more recent research has been really helpful. It led to some of the changes between DSM-4 and DSM-5, and then the research has persisted since DSM-5 came out a number of years ago. About 40% of people with autism spectrum disorders will also meet criteria for the additional diagnosis of ADHD. I did want to say make a couple of comments about that. In order to get an ADHD diagnosis, you have to have this whole series of symptoms in the inattentive domain and also in the hyperactive impulsive domain. Many of the people with autism spectrum disorder, indeed many cases of ADHD, are diagnosed in preschoolers or in early childhood. And this is a condition where the symptoms have to have onset in early childhood. But I will say that in many cases, I've seen a lot of people where the initial diagnosis of ADHD is made in adolescence or in adult life. And these are both autism and ADHD are lifetime conditions because they're neurodevelopmental conditions. And there are a lot of adults who didn't get treatment in childhood, some of them with autism, and part of that was because they were diagnosed with their autism when having an autism diagnosis precluded you from having an additional ADHD diagnosis. But that doesn't mean that you won't benefit from treatment later in life, both medication, treatment for medication, and then also focused therapy and counseling and support that will help people understand and manage their inattention and hyperactivity. You do see more aggression and oppositionality in the hyperactive subtype of ADHD. So good and effective treatment for ADHD may alleviate those issues. And the more severely impaired children who have more prominent autistic symptoms or more intellectual disability often are more likely to have the combined inattentive type. And then looking at it the other way around, if you look at a group of children who have a primary ADHD diagnosis, about a third of them will have some traits of autism spectrum disorder, which is a really interesting overlap between the two conditions and suggests that they are probably in some way that we don't yet understand related at a neurobiological level. Next slide.
Okay. Pick it back up here. Thank you, Rachel.
Yeah, sure.
So we just highlighted 4 of the most common co-occurring psychiatric conditions. We did want to note that there are many other clinical considerations when working with individuals on the spectrum. Some of the ones that I think need more attention, more research, and more clinical training include psychosis, gender diversity, which I do want to note that gender diversity is not a psychiatric disorder or a condition by any means, but we do know that individuals on the spectrum, we see more gender diversity in individuals on the spectrum compared to people not on the spectrum. And oftentimes they are experiencing higher rates of anxiety and depression or other adjustment related concerns. And so I think this is an area where we need more training. Substance use, very few research studies out there about substance use in people on the spectrum, with some mixed findings in terms of how common this is. And then the effect of trauma and the potential of PTSD is another really important area to consider. So now we're going to turn briefly in our last few minutes to the intervention side of things. And the most researched psychosocial interventions to date for co-occurring psychiatric disorders and autism include cognitive behavioral therapy, or CBT, for conditions of anxiety, depression, OCD, and also more broadly executive function impairments. This is typically CBT that has been modified in some ways for autism. There's also some emerging support for mindfulness-based therapies for people on the spectrum, which I think is really interesting, kind of that next wave building off of CBT. Behavioral, strictly behavioral interventions, so kind of taking the C or the cognitive piece out for disruptive and self-injurious behaviors, also have been well researched and supported. And then parent training for disruptive behaviors. These again are the most researched psychosocial interventions to date for these co-occurring conditions in people on the spectrum. So I mentioned the CBT modifications. I want to just briefly go through the main ones here. These modifications are really important due to differences in the learning styles between those with and without autism, and some of those core autism characteristics that we mentioned, like social communication impairments and difficulties with emotion recognition. So things like increased use of visual aids, additional worksheets or checklists, scripts that people can use. making sure that the language that the CBT therapist is using is as clear as possible and as concise as possible, not a lot of extra words. And really, one of my favorite pieces of advice from one of my autistic community partners is just say what you mean and mean what you say. Just be explicit and clear. Don't just try to be nuanced in what we're trying to say in therapy. Oftentimes a modification is an extended time period, so taking more sessions than the traditional course of CBT so that there is that time to repeat some of the material, maybe slow down the pace, and maybe do some more exposure exercises for anxiety treatment to make sure that it's generalizing in the individual's home setting. Again, we know that people on the spectrum have these focused interests oftentimes. And so if the therapist can incorporate those focused interests, not be scared of them. I know many clinicians think, oh, I can't bring up this topic because then it's going to derail us and we're going to spend the whole session talking about this focused interest. But you can really leverage this and use it as a way to increase engagement and buy-in and motivation in the session. Many times the involvement of family members needs to be increased. So sometimes CBT is just a straight individual therapy modality, but for individuals on the spectrum, you may need to pull in a family member if that is acceptable and feasible. And then therapists also need to be aware of sensory sensitivities. I've had individuals on the spectrum tell me, oh, my therapist, wears this really strong smelling perfume or cologne. I can't stand it. I can't focus in session because that smell is just too much for me, things like that. And then finally, thinking about this concurrent treatment of social skills that might be needed, particularly if you're treating social anxiety. You want to be making sure that you're setting the individual up for success and working on those social skills, either in your own sessions or perhaps they're going to a social skills group separately. And then more didactics about emotion, which is often part of a social skills treatment, that emotion recognition and regulation. So before I pass it back over to Rachel to talk about pharmacological treatments, I just want to highlight that hopefully when you're looking at this list of modifications for CBT, you're noticing that none of them requires a complete 180-degree turn for a CBT therapist. These are relatively straightforward adaptations. It's really about individually tailoring your therapy, your therapeutic strategies for the individual in front of you.
Yeah, so I just wanted to, I'm going to say just a few words about the use of psychotropic medications and pharmacological treatments in people with autism spectrum disorders and co-occurring psychiatric conditions. So psychotropic medications are medications that impact on our neurological functioning and therefore impact on psychiatric disorders. So they are active in the brain and on what are called neurotransmitters, which are the way in which brain cells essentially communicate with each other and talk to each other. There are a lot of psychotropic medications that are, a lot of people with autism spectrum disorder who have psychotropic medications prescribed for them. There is, I will say at the onset, there is no psychotropic medication yet that impacts the core symptoms of autism spectrum disorder, the social communication difficulties and the repetitive restrictive behaviors. We don't have a medication yet that impacts those things. However, we do use medications for the co-occurring psychiatric conditions and sometimes for symptom management in people who are having difficulties, for example, with aggressive behaviors or something similar. Medication regimes can be really quite complicated. So it's really important in every patient who has, who is prescribed, of course, a psychopharmacological or indeed any other kind of treatment intervention, that informed consent and safety monitoring are part of the treatment plan. That's particularly important for people with autism spectrum disorders, partly because for a number of reasons, and here are some of them. A lot of people, because the verbal difficulties and communication difficulties, aren't able to tell us about the adverse impacts of medications. Often the medications are prescribed for conditions, for example, like ADHD, that are lifelong conditions. So medications can be taken for many years, and there are some medications for which side effects become more likely and more serious if they're taken for long periods of time. Commonly used medications in autism spectrum disorders, the common ones are stimulants, which are used for ADHD, and what are called antipsychotic medications. They are more associated than other psychotropic medications with adverse events, as reported to the Food and Drug Administration. And then, of course, if you're using more than one medication at a time, then you really need to understand, as the person who may be responsible for prescribing, or parent or guardian, or indeed the patient, that there's more likely to be interactions between the different drugs, either in the way they work at the neurological level in the brain, or the way in which they're managed by the body, whether that's by the liver or in the bloodstream. Next slide, please. So here are just some general guidelines. The importance of, I can't overemphasize the importance of that comprehensive biopsychosocial evaluation, and that medication should only be prescribed as part of a comprehensive biopsychosocial treatment plan. The idea that it's somehow separate from the rest of the interventions that a particular individual is receiving really makes no sense at all, because if there are going to be responses to psychosocial interventions, either positive or negative, at the same time as you're making changes in medication, it's going to be really difficult to figure out what's helping and what isn't. So that thorough assessment initially, and then the ongoing thorough assessment and careful follow-up is absolutely critical to good psychopharmacological medication management. Everybody should understand what the medication is for. The goals should be really clearly defined, and we should be realistic about what we're trying to achieve. And that's part of this informed consent, consent from whoever it has the legal responsibility for deciding what intervention should take place, and assent from whoever, if that's a minor or somebody with a guardian, ought to also understand as much as they can about what's happening and what the goals are of an intervention. And then that careful follow-up, coordination of care with other interventions is also an absolutely critical part. Next slide, please. Here are some of the things that I bear in mind when I'm working with an individual and their family. This idea of starting at a low dose and raising it carefully and slowly over time. If possible, using one medication. And if you're using multiple medications, making one change in treatment at a time and not making multiple changes all at once. Because if you change 2 or 3 things at the same time, and things get better, then you really, or worse, you don't know which change you made that had either the benefit or the adverse consequence. And then the other thing to say is that we were beginning to look more and more carefully at using medications along with certain kinds of therapy. And what we're beginning to see is that for a lot of conditions, not just autism spectrum disorder, but some of the other conditions in people with or without autism, that the combination of medication and therapy together has better outcomes than one or the other alone. And so that's also a really important thing to think through, and how you're going to make those combinations and tailor treatment broadly biopsychosocial treatments.
All right, so this is our last slide, just to end on, I think, an important reminder about this balancing act that not only clinicians, but family members, loved ones of people on the spectrum need to keep in mind, of change and acceptance. So we know that co-occurring psychiatric disorders can cause a lot of impairment and distress for people on the spectrum, and oftentimes that is really what they want help with. And they would like their clinician to really focus on decreasing that anxiety or improving that depression, focus on that part for the change, while embracing the strengths of autism and accepting that person for who they are, and really meeting them with that need that they have for treating the co-occurring psychiatric condition. So this can be really, really fun to work with individuals on the spectrum and help them see these improvements in the co-occurring psychiatric disorders, which can lead to significant improvement in quality of life. So thank you for this opportunity to talk a little bit about this today, and I will hand it back over to Dr. Kristen Soll for our question and answer time.
Great. Thank you so much. That was a really wonderful opportunity to learn more about all of the different things that might go hand in hand with an autism diagnosis. You know, and I think as we start talking a little bit together, here we have, you know, we have a parent, we have a psychologist, we have a psychiatrist, and we have a social worker who are all intimately involved in, you know, the lives of people with autism. And I think that this is a great opportunity for us to just kind of think out loud about how we do that balancing act of change versus acceptance. And so I wanted to start there with that conversation. And so Ellie, would you mind talking to us a little bit about that notion of change versus acceptance in the context of autism, and thinking through, you know, as a mom, how as we try to work, you know, I'm a mom, as I try to think about my own daughter and trying to accept who she is, but also help mold her into a happy, successful human being. How do you think about that in the context of autism and some of the topics that we've talked about today?
Well, it's very difficult because that goes through our heads all the time with our son. You know, he's now going to be a teenager, and with certain things with puberty and social interactions with his other classmates and friends, you know, there's a society rule on how you're supposed to be at this age, and he is not, and it's panicky because he doesn't fit into the cookie cutter idea of what a 13-year-old boy is. And sometimes we force him to do things that he doesn't want to do. And we have to step back and say, stop, this is not his life image. This is not helping him. This is not what he enjoys. And it's only making him more anxious and more depressed and asking us questions as to why we're making him do that. We're constantly taking a step back to see and to identify what type of person he is, because, and it's a daily, constant thing. Every day we do it, because he challenges us every day. You know, tonight his brother's having his first communion, and it's his birthday as well, his brother's birthday, and he does not want to go because he does not want to sit in church for an hour, and that's going to be it's going to be a challenge that he's going to have to do. But he spent all morning long telling us why. You know, other kids, they're all going to go and they're going to sit and they're going to do their thing and they're going to go home. Ours is going to be a little different. So, and we do different planes of attacks with him. It keeps you on your toes and keeps you thinking. So,
yes. Don't you think, you know, I think that, I love that about people with autism, autistics, depending on how you like to be referred. And, you know, to me, that's a strength, right? It's an opportunity to actually get a chance to verbalize what it is that you want to see. I think so often in society, we are shaped and molded by what others expect of us. And
yes.
Yet here we have an opportunity, and you just described that, where you're getting to hear what exactly it is that he wants to do. And it's not shaped by the expectations of a first communion, right? And so what an interesting way to go about life, being able to say, no, actually, this is how I'm going to engage in first communion, and, you know, in my brother's first communion. And I think it's in a way, I learned so much about myself when I'm working with people with autism, because I see it as such a refreshing opportunity to think to myself, what exactly do I want? Because so rarely do I get a chance to ask myself that, because many things I do are for other people. And so I love this notion of you all every day looking at the balance between acceptance and changing. And I think that it's a great opportunity for us to all grow together and learn from that. So thank you, that's great. So Brenna, when we're thinking about opportunities from a therapeutic standpoint, I think that what I often hear from autistic people, as well as their caregivers, loved ones, is how hard it can be to find someone who understands this balance between acceptance and also moving someone forward towards a goal. Because I also know that currently our society, you know, our workplaces, our schools, you know, various societal constructs are very much set up in a way that you do have to follow some rules. And therefore, there are opportunities for us to kind of shape expectations, if you will, because we can't all do everything we only want to do. And so how would you help from a therapeutic standpoint balance this idea between changing and accepting someone who might be coming for an intervention?
Right. That's an excellent question. For me, it really comes back to our earlier points about, you know, impairment and distress. And as the clinician, I may think I know what is impairing. So I think a classic example is someone, you know, let's say it's a teenager on the spectrum, comes in, the parents are upset because they only have one or two friends. The parents are really distressed about this, and they want to work on increasing the number of friends that this adolescent has. One of the first things that I want to do is talk one-on-one with the adolescent and see, is this an area of concern for you? Sometimes it really is, and they're feeling lonely, and they are really distressed by it. So, okay, now we're all on the same page. Let's work on that goal. Other times they are perfectly content with their one or two friends, and they are getting what they need out of that. And it's really our own kind of, like you were just saying, societal or, you know, our personal expectations that are telling us, no, that's a problem. We have to work on that. And so I think for me, it's really spending that time early on to clarify what is getting in the way for the individual and for the family. You know, what is impairing, what is distressing, and then we want to really focus on those. And I think with my work with autistic adults, oftentimes they come into the therapy session, they really see autism as part of their identity. They're not looking to change that. They're looking to decrease the anxiety or improve the depression, for example. And they've had really negative experiences with mental health clinicians who immediately jump to, well, let's try to fix this autism thing, and let's focus on that. And that's just not what they're coming in. That's not what they're coming in for. And it feels like an attack on their identity. So those are my thoughts about that.
I love that. Thank you so much, Brenna. So, you know, there are times when things are very distressing. As a person, I have anxiety myself. And so I know that it can be really difficult to deal with anxiety, and it can be really hard to manage those thoughts as they're getting more and more anxious. And so I know that there's a place for both therapy and medications. And so Rachel, help us to think about, you know, if a parent might be reluctant to engage in either therapy or medication to address some of these issues, how do you help them think through that? How do you help think about the role of those different types of modalities in the treatment of some of these additional needs that might be going on?
Yeah, I think it's a great question, and it's a dilemma for, you know, a lot of families and individuals, both with and without autism spectrum disorders. I think the really, as a clinician, it's my thought is always, let's meet you where you are and understand what you're bringing into the room, and whether and I can say, you know, here's what the research says about this particular medication or this particular therapeutic intervention, but it doesn't say anything about how that will be for you, and how that your child will experience either that particular pharmacology or that particular therapy. And so let's have a conversation about what you're trying to achieve. And the other thing I will say is that people have bad experiences, or they know people who've had bad experiences, or they've read something or seen something or heard something that they led them to have information that may actually not be accurate about what's being proposed. There's an awful lot of stuff around on the internet and in popular culture about what psychiatrists do, what psychotropic medications do, and what they don't do, and a lot of it's not accurate. So having that conversation that says, no, I don't want your child to be a zombie either. I have no interest in your child being a zombie. If your child's a zombie, I failed. Those kinds of things, nor do I want them to be, and I'm also going to be realistic. This medication is not going to transform them, and it's not going to turn them into not the child that you know, because the child that you know, the medication isn't going to do that. And I don't want to do that either. That your child is a unique individual. So having those conversations and being really open about it, I think is really important. If I really do think that there is a good chance that a particular intervention, a particular medication will be really impactful, then it's my responsibility to say that. But I can't force anybody to do anything or take anything. So and then to have that ongoing conversation that's really realistic and that says, okay, we tried that, didn't work. Well, we talked about what we would do if it didn't work. And it didn't work, or it had this particular adverse side effect. And here are the options that we have right now. And engaging somebody and having that relationship that's ongoing and over time develops trust. And I think it's in the context of that trust that you can have the best outcomes that you possibly can have with whatever intervention you're working with.
Great. I think that's wonderful. And I think I like to describe what you just described as shared decision making, right? Parents and clinicians working together hand in hand to make shared decisions. Science and literature is very clear that as a physician myself, if I tell somebody to go do something, but there's no reciprocation in that decision making, it's not going to work very well. And so that conversation, that mutual respect as we build that decision together makes so much of a difference. And so really appreciate that thought, and really working on those things together is a very, very important piece to the relationship. And so along those same lines, a lot of times there is a lot of misinformation out there, a lot of groups trying to engage with parents, trying to get the latest and hottest information in the hands of families. One of the really important things that we do within ECHO Autism community is just try to disseminate best practice evidence-based information. And of course, it's tough because things change on a regular basis. And so there are definitely lots of resources out there. But, I'm going to direct this question first to Ellie and then to Melinda. From a parent's perspective, how do you help people navigate the challenges related to alternative treatment options? And as you're thinking about choices related to medications or therapy or alternative options, complementary options, if you will, how do you think through those, and what advice maybe would you have for those families out there trying to figure out, where to turn and where to go?
Well, my son is on medication, and I'm very upfront and honest with parents that ask me about that, because there is a taboo about certain types of things, like you're putting your child on medication. Well, we tried everything else that came down the pike with therapies, with therapists and whatever, and his quality of life was just, school was just being interrupted. I tell parents, you have to step aside. I respect their feeling about medicine versus not medicine, but it's not about you. It's about your child, and it's about helping him or her achieve as much as they can. I know that medicine is not going to change Patrick's autism. I know that's him. That's his identity, like Brenna said. And we fully embrace that. But for him to be able to sit in a classroom for an hour and do his work and achieve success, that's what we're going to need to do, and it's worked for us. So, but on the other end, with alternative medicine, I mean, we've tried it before, anything, you know, because sometimes the therapies that you need, you're waiting and waiting and waiting. And I get parents get told your child has autism. Oh my God. Well, I've waited all this time for being told that. And now I have to make up for all this time to get help for this child. And now you're telling me I have to wait more, or there's nothing I can do in this type of area. It's frustrating as all heck. And then you got somebody that comes down the line and says to you, hey, if you use essential oils and rub lavender on your kids' feet, then they're going to be able to sleep and get through school better. I've actually done that. That's honestly, I did that. I tried. It doesn't work. But you're so desperate for the help and everything, and money costs. That's a different thing too, you know? So yeah, it's a juggling act, but you know, you can't judge the parents, but you want to try to push them. You got to remember it's for your child, not you, you know, that's with everything.
I think that's so well stated. Thank you so much, Ellie, because right, we all are trying to work toward the helping move forward the child. And I think you said that so well. And who wouldn't want to try something that seemed to be in the best interest of the child, right? And I think that's what is so important in the context of a shared decision-making team, is to be able to think through those things, to help think about, well, would this be an option? What would I expect to see if I tried lavender oil? You know, what are the things, what are the information that would help to make those decisions and is consistent with my family's values? I think those are all such important pieces, and you hit those all so very well. And so Melinda, when we're thinking about accessing resources, figuring out where to go to get this type of support and help, what do you help, how do you help think through this with families, or what kind of information would you share with families about getting advice and support for themselves?
That's a great question, Kristen. And I think I really encourage families to develop their support network. It's really important to find supports in the school system, find a social worker, a therapist, a psychiatrist, a family, a coworker, and really build a support network of people that you can go to. That's first and foremost, to have that. And then next, looking at places like the National Alliance on Mental Illness is a place where families can go and access information about both family supports, peer supports, where to go to get mental health interventions. I think that is a great place to direct and steer people to. In Missouri, we have NAMI of Missouri, and they offer information dissemination options, so that you can contact them and you can find out where to find help here in Missouri. You can find crisis response lines and speak to somebody about getting those resources you need to help your family member. Also in Missouri, and most states have community mental health centers. And those are a great place to direct families to go to gain access to mental health services. Also, the Department of Mental Health here in Missouri has a wonderful website with loads of resources and an easy way to access your local community mental health center. And one final place that I try to direct families to when it's appropriate is the Autism Speaks website. They have lists of resources, and then also the Autism Speaks response team. You can actually call and they can share information about resources in your own local community. So I think I want to equip families with resources that they can choose from, and really encourage people to build a support system so you have somebody to reach out to when there is a crisis or when you do need help.
Thank you, Melinda. That was really helpful. And so this has been a great opportunity to really review what is a disorder? What does that mean? Where do they come from? You know, and it's a lot about figuring out when do we try to support some change to advance towards a goal, right? To advance towards helping someone move forward toward a goal that that family or that person has. Also, though, coupled with acceptance, accepting the wonderful skills and abilities that each of us has. Each of us have skills and abilities that are valued in different ways by different people. And so certainly we know that autistic individuals have phenomenal abilities and skills to share with all of us. I learn every day from my patients and from the people that I work with who are on the spectrum, and it's such a privilege to work alongside them. And one of the things that I think is so important for us to remember is that we do have a significant gap in the knowledge base of professionals in mental health. And we are working hard to try to address some of those gaps. And so I would encourage you, if you're listening, to really reach out and continue to keep learning. You know, for years, we have all learned under certain constructs about this is what this means, this is what that means. And yet science continues to advance. The only way we can develop more opportunities for people on the spectrum and not on the spectrum to get the kind of care that they need, to experience the kind of care that Rachel and Brenna and Ellie and Melinda and myself have been talking about, is to keep learning, to keep engaging, to keep learning from people who have anxiety, who have depression, who describe themselves as autistic. We have to keep learning together so that we can keep expanding the ways that we care for and about each other. So we hope that you'll join our conversations that we have on social media channels and ECHO Autism communities. We also hope that you will continue to engage in learning, because the only way that we're going to continue to provide and fill the gaps that we know are all around us is to continue to learn together. So we so much appreciate your time and opportunities to learn with us today. And we look forward to seeing you next time. Thanks, everybody.